Hello, people. Let's get this meeting started. Oh, Winter Sparachin is. I was confused. Why was Lexi confused? But Winter's got no idea. Anybody know what we're confused about? What was that email about? Well, we have a quiz today. So everyone check your email. There's a quiz there. I would like you to spend about 15 minutes answering those questions, and then we'll talk about the answers. It's kind of like a little review for the exam. And then after that, I'll answer any questions you have, and maybe go through the PowerPoints if you want me to do that. So go ahead, guys, take about 15 minutes here and do that quiz. And then I'll be back to bother you later. Well, I'll be here. I mean, I'm not going anywhere, but you know what I mean. I'm going to do a little Facebook. Kind of a snap quiz, a sudden thing. Okay, go. Okay, if you came in late, check your email. There's a quiz there. I want you to do that, and then we're going to talk about the answers in about 10 minutes, 15 minutes. Winter. Do we email the answers? No, we're going to talk about them together. Quiz. I know. I make it a quiz to increase the anxiety. Okay, people, ready to talk about this? 34 people here today. Let's see if I even have it open. I do not. Hang on. Wait right there. You wait right there. Um, okay, let's see how smart you people really are. Okay, this first one's pretty easy. Jack is 5'7", 150 pounds. His father is 5'6", 200 pounds. His mother's 5'2", 150 pounds. Of these three people, who has the lowest volume of distribution for alcohol and why? Okay, bad news, Carrie Murphy. You're on the top of the list over here, so you need to answer this question. Carrie Murphy. There she is.
I said Jack's mother for this one. Because like women that, well, since she's smaller, like women have like a higher body fat percentage, and since they're usually smaller, this like decreases their volume of distribution. And since like the men are bigger, so to speak, they have like a greater volume to like dilute the alcohol, which gives them a higher volume of distribution.
Okay, more or less. The only point you got wrong was Jack is 5'7", 150. She's 5'2", 150. They're about the same size, 150. But you're right about the fact that women have a higher body percentage. So even though they are more or less the same size, she's got a smaller volume of distribution because she's a woman. We don't hold it against her, though. Okay, thank you. You're humble and lovable. Okay, a symptom that recovering cocaine addicts experience is anhedonia. I talked about this, which literally means a lack of joy. They have the inability to feel pleasure in normal everyday experiences. Why do you think that recovering coke addicts would experience this? Farouk Nisselbay. I imagine you've had a lot of experience with coke addicts. You seem like that kind of person.
I can say I haven't. Would it be because that's them experiencing withdrawal? Withdrawal would be the opposite of what the high is.
That's okay. So that's the withdrawal. This is like after withdrawal is over, they still feel this anhedonia. Joy.
So I forgot what it was. It's the like their mood would be like set down through like down regulation of the receptors.
Not receptors, but downregulation of what and upregulation of the other thing. This is from chapter 5, really, but it applies here. Do you want to get off this stump? Shall I bother somebody else?
Yeah.
Okay. De Giovanni Jupiter. What do you got for me? De Giovanni, are you awake? Are you here? Oh, there you are. So basically, the withdrawal is because of a depleted dopamine and downregulated dopamine receptors. Now we've gotten past all that, but these people still can't feel joy. What's going on long term?
Because of the anti-reward.
You're right. You're right. Can you go with that?
Let me gather my thoughts.
Reminded me of a Pink Floyd lyric. Gather my far-flung thoughts together. I don't know what you're doing, but I'm going to see if anyone else has an answer they want to give. Permanent damage to the receptors, Stefan McKean says. Oh, sorry, that was privately. Permanent damage to the receptors, I would say no. Receptors don't get permanently damaged. They get temporarily downregulated, but that can come back. That can be replaced. No, so DeGiovanni's talking about the anti-reward system. And remember how we said as you go from use to abuse to chronic use, you get downregulation of the pleasure circuit and upregulation of the anti-reward circuit. And the word I was looking for here was neuro adaptation, neuro changes, permanent changes in the neural pathways. So you get a more permanent downregulation of that pleasure circuit and a longer lasting upregulation of the anti-reward. So that's why that anhedonia lasts, and then it lasts for a year or more. It could last a long time. Okay, you're almost there. Okay. Morphine is a poor drug to use for emergency pain management because it takes a long time to produce its effect. However, it can be very effective at 1% its normal dose if injected into the spine instead of into a vein. Why is this? This is a pharmacokinetics question. Who do I go to for pharmacokinetics? Oh, I know who I'm going to. I'm going to Natasha Thakur because she always gets the answers right. Natasha.
Hi. I said when it is injected in the spine, it would get to the brain a lot faster. Injection into the spine will help administer the drug directly into the subarachnoid space that contains the cerebrospinal fluid.
Okay, and why is that faster than just injecting it into the vein? Because there's really slow circulation of that fluid, but still it's going to get there faster than in a vein. Why do you think that might be?
Just because it's more direct. Also, yeah, just that, I think.
I don't think so. I think if you had fentanyl injected in the vein versus fentanyl in the spinal fluid, fentanyl would operate faster in the vein.
If you put it in the vein, it has to go through the blood-brain barrier, right?
Correct. Who said that?
Melon.
Gamellan? Was that Matt Gamellan?
Yeah, it was.
Okay, good. And remember, there's that one figure from the book that said that like 85% of the morphine is in the charged form and it can't go through the blood-brain barrier. So putting it directly across the blood-brain barrier would get it there faster. And Farouk, never mind. Okay, so that was the quiz. If you did well on that quiz, congratulations. If you did poorly, send me an email and I'll subtract some points from your overall score to penalize you for doing bad on that quiz. Okay, so let's see. You can do reactions. So down the bottom, you got reactions. Let me see your thumbs up if you want me to go through the PowerPoints. Or no, tell you what, I'm going to go through the PowerPoints just to kind of review. If you don't want to stick around, you don't have to. But those of you who do want to stick around, I'm going to go ahead and do that. Let's start with alcohol. Alcohol. Okay, types of alcohols. It's kind of important in that you should know that this is the one you drink and these are the ones you don't drink. Concentrations. These are kind of important. I can sneak them into a question here or there. This is important. Your ADH, we'll talk about this quite a bit, and also ALDH. So ADH is getting rid of the alcohol, but then this is really toxic. So then when you convert it to this enzyme then allows it to go into something safe. So if that enzyme gets blocked, then you're in big trouble. And this is a drug that blocks that. Okay, approximate blood percentages, that's kind of interesting. That's more for your own knowledge. I probably wouldn't ask you that. If I did, I'd have to give you the graph. Well, actually, you have access to the graph, don't you? It's open book. Okay, this is a question we had today. Here's two people the same size, one male, one female. Because of her extra body fat, she's got a lower volume of distribution. Zero order kinetics. I like to ask questions about this sometimes. This may come up. Mechanism of action. So this again is probably more for your own personal information, knowing that this is about where you start to lose control, and then you can end up getting arrested if you try and drive in there. Up in here, I hope none of you ever get to this end of the scale, because that's pretty nasty stuff. Okay. Mechanism of action. This is really important. This is what I love most about this whole class is mechanism of action. So alcohol is going to increase GABA stimulation. So it's going to increase IPSPs, and it inhibits EPSPs by inhibiting glutamate. So remember, GABA and glutamate are the two major neurotransmitters that do 90% of everything in your brain. So this alcohol is hitting both of those, and both in an inhibitory sense. And also that tells you what's going to happen with the receptors, because if you stimulate the receptors, like with the GABA receptor, they're going to be downregulated. And if you block them, they'll upregulate. So that's why, for both of those reasons, that's why when you withdraw from alcohol, you get hyperexcitable. And that's what the delirium tremens is, the DTs, just hyperexcitation. High dose alcohol, now that was low dose. So at lower doses, it's having specific effects on specific receptors. At higher dose, it's just kind of mucking up your whole brain. It's acting like a local anesthetic, or not local anesthetic, an inhalation anesthetic. It's a nonpolar molecule, nonpolar-ish, and it dissolves in the membranes and decreases the fluidity of the membranes, and then the receptor, or the ion channels in the membrane stop working. Here is how it works in the brain. Why you get what you get. Let's see. So we're going to weaken this willpower pathway here. This is a glutamate pathway, so we're inhibiting glutamate, so we're decreasing inhibition, and inhibition is your willpower, so you weaken this. Oh, and also in terms of mechanism of action here, we're indirectly releasing endorphins, and endorphins are stimulating euphoria in the nucleus accumbens, both directly and by decreasing the feedback inhibition here from this GABA. And we'll talk about that more when we get into opiates one chapter from now. So, but what I'm trying to say here is this glutamate inhibition pathway is downregulated. So you're losing your inhibitions here. Okay, positive effects of the drug, peripherally, 1 to 2 drinks a day. For men, you can go as far as 4 and break even, but a couple of drinks a day, you're going to make your lipid profile better, lower your LDL, increase HDL, and it's actually protective against heart attack and stroke. And this is the peripheral effect. If you've got too much LDL in your blood, you start to develop this plaque, and the plaque can cause a thrombus, which then gives you a heart attack. So alcohol can help you to avoid some of this. If you are a woman and you're pregnant and you're getting drunk every day, it's not a good thing. Fetal alcohol syndrome of the child afterward, because if mom's drinking, the child's drinking too, and you get all these developmental problems. And this is a lot of alcohol. This is getting drunk every day, basically, not a glass or two, but really overdoing it. And there's a lesser version of this, which is alcohol-related neurodevelopmental disease or something like that. And that's like similar, but milder. And that's a little less alcohol every day. And here's the faces of people of fetal alcohol syndrome. Some of the problems of FAS. And the outcomes. Okay, so tolerance to alcohol. This is important. I like to ask questions about this too. Acute tolerance is like while you're actually drinking the alcohol, it has less and less effect over time. Even though the alcohol concentration in your blood is just as high as it used to be, it has less effect because you've got this short-term acute changes in GABA and glutamate. You're going to downregulate GABA activity, upregulate glutamate activity, and that's going to balance out some of the effect of the alcohol. So even at a constant BAC, you're going to feel more sober. Metabolic, that's your liver and to a certain degree your stomach breaks the alcohol down faster. So that means you're going to get less in your system for the same amount drunk, and also it's going to leave your system a lot faster. And this is more chronic. This is acute. This is more chronic. The more you drink, the better you are at drinking. I'm pretty practiced myself, frankly. Pharmacologic, this is kind of the same as this, except more chronic. Oops. So in the acute phase, you're just phosphorylating the receptors and they have less effect. In the pharmacologic phase, you've actually downregulated and destroyed those receptors. So this is going to take longer to regenerate. And this is why withdrawal, like this would be like a hangover. Like the next day you feel really crappy, which is like hyper excited and just crummy. And then this is more like withdrawal. You chronic alcoholic, you stop taking the alcohol and you really go into hyper stimulation. And then there's learned tolerance, which is basically learning how to act sober when you're straight. I had one good friend who we didn't know he was an alcoholic because he was so good at hiding it all the time. So you learn those tricks when you need to. So here's acute tolerance. Here, this person's drinking drinks at here, and here. Alcohol concentration going up in the blood. Here it's at 0.1, say about 0.2. Here it's even higher, but he feels sober. So here this person feels drunk. Here they feel sober, even though the alcohol percentage is actually higher. That's a pretty high alcohol percentage for 3 drinks. Geez whiz. That's like 0.25. That's like falling down drunk. Okay, metabolic tolerance. Before, for 1 drink, the alcohol stays in your system this long. After, it comes out a lot faster. And here's this woman with her chronic alcoholism. Her BAC was almost 0.39. Now, technically, she should have been dead, but she was still driving her car. Chronic abuse results in liver damage. So first, your liver gets fatty because it's, there's a lot of calories in alcohol, and it's not accompanied by vitamins. You tend to, because of the increased urination, you lose a lot of your vitamins. So now you've got a lot of high energy molecules and nothing to do with it. So your liver stores it as fat in vacuoles, and the vacuoles get bigger and bigger. So you get this fatty liver. If you keep on drinking more than that, those fatty globules will end up killing cells. So now you've got fibrosis because cells have died, and other cells have come in and replace those cells with collagen and other extracellular matrix proteins. So now you've got fewer cells, and it's all kind of fibrous. And then cirrhosis is then when that process just continues to the point where you really don't have that many cells left, and your liver is all just it's all fibrous tissue, and typically you die from that. Was it this class? No, a different class. I was talking about how the proteins in your blood help keep water in your blood And when people get into hepatic cirrhosis, they get edema all over their body because they have so little protein in their blood. And usually what you die from with hepatic cirrhosis is pneumonia, because you get edema in the lungs from this, and that causes you to suffocate, basically. And there's your cirrhotic liver. Yum, yum. Some onions, fried up with some butter and onions, yum. Okay, and also chronic alcohol abuse, you get brain shrinkage. Here's your ventricles, and you see how much bigger the ventricle is here, and that's because cells are dying back and your brain is shrinking. And that's about it for alcohol. Any questions about alcohol? Oops. Last time I looked, I saw that we couldn't review homework quiz number 7. Could you possibly open that up after class? Can I do that? I don't know if I can do that. I'll see. Let's see if I don't think I can do that though, because if I open it up, you can take it again, and I can't really do that. Which part of the brain dies first? Is it always the same? I don't know the answer to that question. That's a good question. I think your willpower pathway dies back quite a bit in all addictions, but I'm just kind of making that up. I don't really know. Yeah, I don't really have a good answer for that. Any other questions about alcohol? Okay. In that case, we will go on. When the alcohol stops working, what do? You go to opiates. Yay, opiates. Bum, ba, ba, bum. Come on, opiates. It's a nice field of poppies. Must be in Afghanistan. That's where most of it comes from, frankly. Here's your poppy. So there's the flower. After the flower goes away, you have the seed bud. Scratch it, and the juice comes out, and that's your opium. Just scrape that off and dry it. It's opium. You could smoke it like that. Back in the day, you could buy any of this stuff over the counter. Heroin you could buy over the counter. Paregoric and laudanum are just tinctures, I believe, of opium. So they've got morphine in them. Here's black tar heroin, purified heroin. Okay, oral absorption, slow onset with the first pass effect. And this is the way the doctors want you to take it because it has a slow onset. Slow onset means you're not going to get the rush and you're not going to get addicted to it, at least not as easily. Injection, that's where you get the rush, and it's much more addictive that way. Remember, the faster it comes on, the more addictive it is. Here's injection. These are the kind of pictures that make you want to do heroin. Yeah, good stuff. Okay, rate of crossing the blood-brain barrier. Methadone's the slowest, very, very slow, then morphine, heroin, and fentanyl. And addictive potential is just the opposite. And for that reason, the faster it gets into your brain, the higher that rush goes before your anti-reward system kicks in and brings it back down. So the faster it gets into your brain, the greater the rush, and the more addictive it is. Here is morphine and heroin. Again, heroin is also called diacetyl morphine, and that's because you've got basically morphine with 2 acetyl groups on it. And this can get across the blood-brain barrier a lot easier, and then it gets metabolized into morphine once it gets into your brain. Here's fentanyl. Structure looks nothing like these two, but it's very nonpolar and activates the same receptors. And here's what I was talking about in my class today. If you inject it directly here into the brain, it's going to have a greater effect than if you inject it in the blood, and it has to slowly get across that blood-brain barrier. And it's going slow because only 15% of it at any one particular time is actually in the nonpolar form and able to get in. Most of it is polarized up here. And here's the heroin going across the blood-brain barrier being metabolized. Okay, distribution. The more nonpolar it is, the faster it gets into your brain. So there's fentanyl, heroin, morphine, and methadone. And again, that predicts its addictive properties. And this is why. So the faster it gets in, the higher that rush is. Okay, you're still going to get it with the slower ones, but not as much. And again, it's because if you remember this from chapter 5, and I'm sure you do, once the rush starts coming on, the anti-reward starts to bring it back down. And so the faster it comes on, the higher it can get before that anti-reward comes in. Okay, so if you want to do pain management, what do you want to do? You don't want this. You don't want rush valley, rush valley, rush valley, rush valley. You want something that's going to stay up a lot longer. So this is OxyContin, which is supposed to be less addictive, and it is, except for the fact that back in the day, people would crush it up, and then you're getting like woohoo up here instead of that that longer release, which is the way it was supposed to be. Fentanyl patches even better, except again, you know, an addict will take that fentanyl patch, break it open, and suck on it, and then off to the races. Methadone is probably the best for maintenance because it's administered orally. You have to stand there and take it in front of the practitioner, and it's going to take 12 hours to peak and 12 hours to start going away. You take it every day, and you just get this even keel thing. And again, the thing is, if you're doing this to someone who is, you're doing this with someone who is very addicted to opiates, they have very low levels of opiate receptors. So what you're doing is not getting them high, you're just keeping them even, because if they stop taking it, they were going to withdrawal. But you're still not getting the peaks. You're not getting the peaks of the valleys, you're just staying normal. So they don't even feel high, they just feel like they're able to live a normal life again. And there's all of that crap. Okay. Mechanisms of action, you've got enkephalins, endorphins, and dynorphins. Enkephalins we don't talk about much. Enkephalins and the DORs, there's fewer of them and there's less of an effect with them. The main things we talk about are the endorphins, which are going to activate the MORs. Dynorphins, again, interesting, but not as big a deal here for this chapter. So all of these are involved in sexual behavior, pain modulation, and also mood. And they can be released by exercise, sex, and injury. Mu opioid receptors, the MORs, these are the most important to us. They're the ones that people are activating with heroin or their addictive drug of choice. Produces euphoria, relieves pain, causes relaxation and sense of well-being. Higher doses cause respiratory depression, and that's how you die when you're doing opioids. The delta opioids, they're there. They don't seem to do as much, so there's not a lot to say about them. The kappa opioids are involved in that salvia divinorum. Oops. That trying to get to the chat here. Yeah. Carrie Murphy, is there a question on chat? Can you read the question for me? Carrie?
Someone said, so OxyContin is more addictive than fentanyl?
No. OxyContin is pretty much the same as oxycodone, which I believe is Vicodin. So they're about at the same level. Fentanyl is more addictive. And the difference is it's less dose than the polarity, because that fentanyl gets in your brain really fast, gives you the rush, whereas these other ones get in slower, and so less rush, less addictive. Still addictive. I mean, don't get me wrong, it's still very addictive, but not as addictive. The big thing, again, about difference between oxycodone and OxyContin is just the dose. There's a lot more in OxyContin, and they grind it up and snort it, and then they're getting a much faster and harder hit. But fentanyl's definitely more addictive. Okay, so again, the kappa opioids are going to cause dysphoria, depression, anxiety. So basically the opposite of the mu opioids. And we've got that one hallucinogen, salvia divinorum, that activates these receptors, and nobody understands why that makes it what it is. Okay, mechanisms of action. Exogenous opiates overstimulate the receptors. So we're really activating, instead of slight modulation with a little bit of endorphin being released, it's major hit of stuff. So it's way overstimulating. And that gives you a pain relief, but also euphoria and sedation. This is the sedation part, people on the nod. Okay, so this kind of sums it up really nicely, I think. Well, of course, you would think that, Dr. Slish, you're the one who made it. Did I just skip one? No, okay. So mu opioids are your endorphins and locations, nucleus accumbens, that's your euphoria. VTA is also euphoria, right? VTA innervates the nucleus accumbens. Thalamus, I'm not sure what it's doing there. I think that's pain relief there in that thalamus. Oh yeah, there it is right there. Holy shit. RES is decreasing RES activity, which is going to cause you to relax. Stimulating the raphe nucleus, releasing serotonin, giving this sense of well-being. Depressing the medulla oblongata, stopping you from breathing and causing you to throw up. And then in the PAG and dorsal horn, that's a lot of where you're getting your pain modulation. And we saw that one figure of the sensory neuron leading up the spine and all the reflexes that are inhibiting pain as the pain stimulation is going up to the higher centers. And these are involved in that pain modulation. Enkephalins, blah, 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 DOR, okay, dynorphins. So really, this is what you got to know. I won't ask you anything about DORs, probably won't ask anything about KORs, but mainly it's going to be that. Okay, mechanism of action. Where are these receptors and what are they doing? You've got two different things that can happen. One is the axosomatic. So endorphin neurons from the hypothalamus directly innervate on the soma of cells in the nucleus accumbens. So you're getting a direct euphoria here from the endorphins interacting on the soma. And also you're getting this inhibition of the inhibitor or the disinhibition. So here is the direct activation at the soma. G protein activated, opening a potassium channel, and that gives you an IPSP. But here here's the axoaxonic. So here we're talking, let's just go right to cut to the chase here. Here I'm talking about this connection here, where you've got VTA releasing dopamine in the nucleus accumbens, which then causes the feedback from GABA, and the opiate is inhibiting the feedback. So it's inhibiting the inhibitor, so that's why we call it disinhibition. So that's where you're getting a lot of the euphoria from. And also direct stimulation of nucleus accumbens and inhibition of the inhibitor of the VTA, so you're getting more VTA stimulation. I really like this mechanism. Hint, hint. Disinhibition. Okay, and here it is. And you could click into this. There's the animation you could look at later if you want to. And here's that figure I was just talking about with pain coming in and up to your cortex so you perceive it, but all along the way there's these other feedback loops that are inhibiting the pain. And so you're blocking some of that pain. So again, you cut yourself really bad, you're not going to die right away. You're not going to be in pain right away. You're going to get away from that trauma, that injury, and then the pain's going to kick in. And that's because of these feedback loops that are inhibiting the pain immediately. And here's the stress response. We talked about this a bit in chapter 5, but basically this is part of your anti-reward system. So your amygdala is stimulating the hypothalamus, and then you've got your HPA axis releasing cortisol, which makes you very stressed out. And your amygdala is also stimulating the RAS to make you very anxious. So here your opiates come to the rescue by inhibiting the RAS. So by inhibiting the RAS, you're not going to be as stressed, you're going to be more relaxed, and life is going to be better. I promise, life's getting better, people. I got a new president soon. Okay, dependence. This is drug use, chronic use, dependence. And the whole point of dependence is you need to take the drug to be normal. And when the drug goes away, you go into withdrawal. So this is what methadone is doing, is bringing them slowly up to here, holding them here at normal. And when it goes away, they get another dose of methadone. But this is why you go into serious withdrawal here, because you've downregulated all those opiate receptors. So the normal endogenous opioids are not enough to keep you in a normal state. Oh, that's it for opiates. Okay. What's endogenous versus exogenous? So endo means inside, exo means outside. So endogenous means the neurotransmitters that are normally in your body, the ones your body is making. Exogenous is any drug you take. Okay, so endo is already there. Exo is what you're taking from the outside. Okay, any questions? All right, so let's do our last share. Stimulants. Okay, it's chapter 9, stimulants. Couple of lines of coke. Okay, cocaine, cocaína in Spanish. Cocaine is a pretty boring looking plant. The leaves from it you pull off, and for centuries and centuries, probably millennia, people would just chew on the leaves and get some energy and help them to work harder. But then these smart people came along and found they could extract it from the leaf and make it more concentrated, and now it's a dangerous drug. Here we have for throat troubles, cures nervousness, headaches, sleeplessness. This will do everything. Cocaine tooth drops, right? This makes sense, right? It's a local anesthetic as well as being a stimulant. Vin Marini, like to get some of that someday. Amphetamines, here's where amphetamines come from. The Ma Huang. All right, hang on a second. I'm going to stop my share so I can see this.
Pretty pointless.
Kids on the logo? What does that mean?
I know, that was pretty funny on like the cocaine toothpaste drum or toothache drops. They're like kids on the logo.
Yeah, right.
But
Well, that's what it was
for
for.
everyone.
Yeah, it's like your children are teething, get them some cocaine, or give them some alcohol. That's what they used to do back when my mother was young, which is probably the 30s. Yeah, the 30s to 40s. If children were having teething pain, they get some like whiskey and rub it on their gums, numb them up, which was, I guess, a step better than cocaine, but So Ma Huang is where ephedrine comes from, and ephedrine was the first it's a natural product, but it was converted into methamphetamine or amphetamine and all the other amphetamines. Here's khat, which is, I guess, a North African kind of a thing. Dexedrine, benzedrine, so these are synthesized. And this is how you might make methamphetamine if you were going to do that. And here's what happens if you do that. Sometimes your house burns down. It happens. Cocaine HCl versus crack cocaine. So notice how crack cocaine doesn't look like glass like methamphetamine does, and that's because of the way they make it. Is they take your cocaine HCl, which is water soluble, dilute it in water, add some kind of base like baking soda, and then that turns it into the free base, and then they dry the water off so the crystals have got water embedded in it, and so when you heat it up to smoke it, it cracks. So that's why I call it crack. The other stuff, the free base that they extract with ether is a lot cleaner and purer, but again, ether tends to explode when you have it in your house. So the difference is, here's your free base, and here's your hydrochloride base over here. So this makes it water soluble. This makes it not water soluble. And this also makes it so that it doesn't get degraded in heat. So the big difference here is your cocaine HCl decomposes in heat. It's water soluble, poorly absorbed through the nose. It's because it's usually snorted. You can't inject it though. And then your free base then is treated and either extracted or just dehydrated, and it is heat stable, so you can smoke it. And the pharmacokinetics are very different whether you smoke it, inject it, or snort it. So very fast onrush, but it's got a really short half-life, so it goes away really fast as well. What do they say? The crack cocaine hits your brain in about 7 seconds and lasts about 5 minutes, versus snorting it will take maybe 5 minutes to start and maybe last 30 minutes or something. Okay, and here are the breakdown products. We've got 2 esters here. So the breakdown all has to do with the esters being broken. So here's benzoyl cognine. Take the other ester off, it's ecognine methyl ester. Take them both off, ecognine. And so basically, this is the most likely metabolism product. So this is what they look for in the urine when they want to see if someone has been doing coke. And then this is just to show you that if you drink alcohol while you're doing coke, it lasts longer because you'll get this cocaethylene in your blood, and it's got a longer half-life than regular old cocaine. So here's what I mean about it being glass-like. Free-base methamphetamine is made differently than crack cocaine, so it does have that real crystal look to it, as opposed to the powder over here, which is the HCl version. And there's your free base there. You add a hydrogen to that, and it will then become positively charged, and that's your crank. The chloride then is the counter ion, or crystal meth is without that HCl and just a nonpolar form. Here's norepinephrine, and what I'm trying to show here is how similar all these drugs are to the endogenous neurotransmitter, which is norepinephrine, ephedrine, methamphetamine, amphetamine. Okay. And very similar to crack cocaine or cocaine, HCl versus crack. Crank, the HCl version, will decompose with heat, water soluble, poorly absorbed, injected. It can be injected or snorted or taken orally. See, cocaine really can't be taken orally because it gets broken down really fast by the liver. Free-base methamphetamine then is what you call your crystal meth, and it's heat stable, usually smoked, but can be snorted, very fast, high. Big difference here between cocaine and amphetamine is the half-life. The amphetamine, crystal meth anyway, is very poorly metabolized. 40% of it will just come out through the urine, even though it's kind of non-polar. 60% metabolized, very long half-life. Cocaine, short-acting, free base, short-acting. Methamphetamine, always long-lasting. HCl has to be stored or injected. Free base can be smoked. Nice little animation there. Thank you. Okay. Mechanisms of action. So we've got several here. Cocaine is a local anesthetic, which means it blocks sodium channels, and that blocks pain reception. So the action potentials produced by these pain receptors out here can't get up the axon because you've blocked it. So just like Novocaine or lidocaine or whatever cane they use to take your teeth out. Okay. What does it do in the periphery or in the brain? It does this blocking of this uptake pump. So neurotransmitter gets released in synapse, gets taken up by the pump and put back into the vesicle to be re-released. With cocaine, you block that pump, and so it stays in the synapse longer and it has more of an effect. And this happens in the sympathetic nervous system, which causes your heart to beat faster, your arteries to contract, so you get blood pressure going way up fast. So peripherally, it feels like a fight or flight response. Centrally, it's stimulating dopamine, release, which is giving you euphoria, norepinephrine, which is giving you stimulation, and serotonin, which is giving you that sense of confidence, sense of well-being. Amphetamine has got the same dopamine, norepinephrine, and serotonin effect, but the way it's producing it is different in that instead of just blocking this pump, it's going to reverse the pump. So you're activating production of cyclic AMP through this TARR1 receptor. So producing cyclic AMP, activating the kinase. Kinase is phosphorylating the calcium channel and the pumps. And so you're releasing a lot more neurotransmitter. This is another kind of a thing, this biochemical mechanism I really would like to ask about. So this is something you should know. Euphoric effects is dopamine. We've seen this before. Supersalient, much stronger than any other joyful experience you can have, and that makes it very addictive. Also, your RAS, which is where the norepinephrine is coming from, and your RAFA nucleus, which is where the serotonin is coming from. You're stimulating all of this, producing all of those effects. Acute negative effects. So especially in the nose, if you're doing cocaine, it constricts the blood vessels, and that means that subsequent uses of it through the nose, in the same run, you're getting less absorption of the cocaine. But also, if you're doing it a lot, you're going to get a lot of tissue death in that area, and that will cause a lot of damage. Also, you can get other peripheral damage from this, just activating constricting blood vessels in other places. You can end up with stroke or just ischemic brain disease, ischemic heart disease, or heart attack. Anywhere in your body, if you're overdosing on cocaine, you can lose circulation and cause tissue death. Here's your cocaine nose. Okay. So I just went over this. I don't feel like going over it again. This is here for you to look at. Blah, 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 blah. These guys, meth bugs, right? Because you're so overamped, you're like stimulating, you're scratching yourself. Sorry. Oof. This is a good ad for methamphetamine. Yikes, meth mouth. Meth mouth. And causes you to age really quickly, as you can see here. This woman, 2.5 years. Yikes. And that is 4 years. 3 months. Downhill, downhill. And that's it. That's all I have for you. Any questions? Any comments? Okay, we will have an exam on Wednesday. I probably won't be here. Just log on and do your exam, and I will hopefully be able to grade it by the end of the weekend. I'm not as busy as I have been up for the last 2 exams, so we'll get to that as quick as possible. Okay, people, study. Study, damn your eyes. Stefan.
Thank you.
Oh, grades. Talk about grades. Stefan, let me send you, are you still here? Yes, you are. Let me send you a link because I'm recording this. I'm going to upload it. So we'll have a more private conversation if I send you a link, okay? I'll send you an email right now.